Hello, welcome to AMCI Saturday Study Session, or SSS. I'm Mrs. J, Curriculum Director here at AMCI, and I am delighted to present AMCI Lead Instructor Ms. Tamika, along with her guest. Without further ado, let's get started. Take it away, Ms. Tamika.
Good morning. Hey, how's everybody doing this morning? I hope you guys are ready to roll. We've got some good stuff. You guys know we're doing musculoskeletal and respiratory. Those two things, they go hand in hand, just like the respiratory and the heart, but we're going to string musculoskeletal and respiratory together. Good morning, Rasha, Sharnita, Natalie. Hey, ABC, Renata. Look here. I've got to get rolling back here because I want to be sure we give you guys a great study session. How are you, Kiara, Marquita? All right, you guys, I know that you guys got your pen and paper in hand and you're ready to do some good stuff. Hey, Shabakun, Shalini, Sharnita. Look, I got my eye on all of you. You know we keep good watch on you. Grab your favorite pens, your CPT manual. You got to have your baby in hand, some notebook paper, your beverage of choice. We're going to prepare to have a lot of aha moments, all right? I know you've got this. I'm confident that you guys are rounding the corner. You are going to be more than ready. You know what our study agenda is. I'm going to introduce my partner, my right hand, okay? She is phenomenal. We'll then roll into that copyright. We don't have any announcements this morning, all right? Remember your steps to solving that time scenario. Remember the who, what, when, where, how. Hone in on those keyword concepts, remembering that certain words in that scenario are pivotal to helping you to make the correct code choice. And your facts to remember as you go through and you're chunning your book, please take the time to put those facts to remember somewhere on that page. That's like your map, your GPS, so to speak, to help to orientate you as far as what those codes mean, and it'll drive you to the correct answer. So before we get to those time scenarios, I'm going to bring Miss Andrea. Come on, lady. Let's do this.
Good morning, good morning, good morning, coders. Happy Saturday and welcome. Thanks for coming to spend some time with us this wonderful Saturday morning. Miss Tamika has a great class prepared for us, and I will see you guys in the chat. Feel free to drop all your questions, everything in there, and I'll see you shortly.
All right, sounds good. You are in the right class, Marquita. We do cardio on next week. Cardio stands on its own because there's a tremendous amount to study, and that's why we do musculoskeletal and respiratory. All right, so we got you. We're heading into cardio on next week. Never you worry. We're going to get to the heart. All right, so our copyright, CPT copyright 2021. American Medical Association, all rights are reserved. CPC is a registered trademark of the AAPC. AAPC content found within this presentation is copyright of AAPC. Keyword concept, FTR, Chun, AMCI, FAT7, Flip, Tap are trademarks of AMCI. All right. And again, remember, we want you to look first at those answers. That's going to help you as you are looking at that scenario to eliminate those wrong answers immediately. Look for those modifiers. We did a little of that last week. Your diagnosis and procedure codes, which of those share the same codes and how those codes are sequenced. Understanding that a simple repair, if that were sequenced before complex repair, that would be incorrect. The most complex procedures are always sequenced first. Again, find those keyword concepts. Continue to churn your books. I know you guys are either finished or you're in the process of rounding it out and determine the differences between those codes. All right. Remember, you do not code preoperative diagnosis in the setting of a postoperative diagnosis. Things not confirmed by that doctor. All right. If he didn't say it, it didn't happen. All right. Or we don't code those products that a physician uses for closures as well, because most of those closures, they are bundled. So remember that as well. Things that are bundled within a code, that will help you. All right. Because you guys are studying for your CPT and CPC exam. You guys know that CPT book, yeah, it drives the money for professional coders and facility coding. The ICD-10 book drives it, okay? But we're focusing on the CPT manual today. All right, respiratory. That's where we're going to start. All right, we're going to jump right in. Yeah, I want you guys to blow me away. These time scenarios will be 2.5 minutes. Miss Andrea will start out with our first one, reading first your answers and then the scenario, and then I'll start the timer. All right, guys, you got this. Yes, ma'am, Kiara, CPT all the way. You have your ICD-10 code manual with you. That's used to break the tie. Remember, I always tell you guys, stay in the CPT manual 95% of the time. You can pull out the other manuals if you need to break a tie, okay? But most of the time, CPT. All right, here we go. Come on, Miss Andrea. You have the floor.
Okay, coders, we have A 31628, B 31628 with 31632, C 31629 with 31632, D 31628 with 31632 times 4. A 20-year-old patient is seen for 5 transbronchial lung biopsies of 2 separate lobes. One biopsy is taken in one lobe and 4 biopsies in another lobe. What CPT codes are reported? You got this, coders.
All right, coders. I think everybody's got their answers in there. I saw some great keywords and some terrific answers this morning. I am really, really pleased at what I'm seeing. You guys are getting those keywords down. And hey, to solve this one, you really had to hone in on those parenthetical guidelines, and that you guys did. So I'm not going to spend too much time on it because you guys are well on your way. So let's just jump right to it and we'll just reiterate what you guys obviously knew. Okay, so we've got that 20-year-old patient. They are being seen for 5 transbronchial lung biopsies, 2 separate lobes, 1 biopsy from one lobe, and 4 from another lobe. So we know the answer is B. And I'm just going to go through real briefly how we got there. All right. We know when we look here at this code family, 31622 is the parent, bronchoscopy, rigid or flexible, including fluoroscopic guidance when performed. So we're going to take a look and start looking here. This one is with transbronchial lung biopsy or biopsies, single lobe. Okay, so that looks good to me because we know we've got 5 transbronchial lung biopsies. So yeah, and they're in 2 separate lobes. So this takes care of one. So we're going to give that a light yes because we've got a little bit more exploring to do. So let's take a look at our parenthetical guidelines. It's telling us that 31628 should be reported only once. That's pivotal, regardless of how many transbronchial lung biopsies are performed. And if we have an additional lobe, we are to use code 31632. Right here, we are already able to eliminate 2 answers. We're already able to eliminate A, because we know we're going to need an additional code because we have yet one more lobe to take care of. It's telling us 2 separate lobes. So we know we can eliminate this one. We know we can eliminate this one. We do not need a multiplier. Whenever you have biopsy or biopsies or whatever the word is, if you have this, if it said nodule or nodules, we know we don't need a multiplier because it's taking care of one or more. So always keep that in mind. That applies. So we don't need that one. That's not coding for that other lobe. So this leaves us with these, but we already know we're not going to take this one because of that. All right. So this one, though, has our 2 codes. That's going to be the lead. When we look at code 31629, this is transbronchial needle aspiration. And we know that didn't happen. We're looking for a biopsy. So we're taking that out. All right. So here we are. We're right there. And already we can get rid of that, but we're just going to do our due diligence. We're going to take a look at that code. It tells us here we've got checks and balances here. This is also this add-on code taking care of the additional lobe that also had a transbronchial lung biopsy or biopsies. There we go with that word again, no multiplier. All right, so we take a look there and we're reading these parenthetical guidelines and other checks and balances. We know we're in the right place. It's telling us use this code 31632 in conjunction with 31628. Again, same wording, only reported once, regardless of how many of those biopsies are taken. So that is our rationale. That's how we got there. All right. And that's how we arrived at B. Okay. If you slightly missed it or you didn't quite get that parenthetical guideline down, go ahead and get your screenshot if you need to. And you guys breeze right through. But hopefully I shared something that you can stick back just to take with you, remembering whenever you see this biopsy or biopsies, if you see anything in there with some multipliers related to the codes that you would need, go ahead and take them off the table. All right, we're going to keep on going, and I'm going to bring Miss Andrea back to the floor, and you'll have 2.5 minutes for this one as well.
Okay, coders, we have A 32098 RT 7702 modifier 26, C 34.10, R07.9, R04.89, R47.81 with R63.4. B 32400 RT 7702 modifier 26, C 34.90, C 32607 RT 7702 modifier 26, R22.2, and D 32405 RT 7702 modifier 26 with C34.11. A 55-year-old female smoker presents with cough, hemoptysis, slurred speech, and weight loss. Chest x-ray done today demonstrates a large, unresectable right upper lobe mass, and brain scan is suspicious for metastasis. Under fluoroscopic guidance in an outpatient facility, a percutaneous needle biopsy of the right lung lesion is performed for histopathology and tumor markers. A diagnosis of small cell carcinoma is made and chemoradiotherapy is planned. What CPT and ICD-10 CM codes are reported? You got this, coders.
How we doing, coders? I'm going to give you guys just a little bit more time. I'm going to be sure everybody has a minute. I'm going to give you guys about another 5 or 10 seconds, okay? And slide your answer in there. All right, I think I have heard from everybody, and no worries if you just missed it. I had several different answers on this one, and I always want you to get your best guess in there. because it'll give me an idea of where I need to focus when I start going through the answers. So no worries if you just missed it. This is a teachable moment. This is why you're making this investment. So let's go ahead and unpack it. Our keywords: this is a 55-year-old smoker. They have cough, hemoptysis, slurred speech with weight loss. They've had a chest x-ray, and it's demonstrating a large unresectable right upper lobe mass. The brain scan is suspicious for metastasis, and under fluoroscopic guidance in an outpatient facility, this patient has had a percutaneous needle biopsy of the right lung lesion, and it was performed for histopathology and tumor markers. The diagnosis was made of small cell carcinoma. All right, the answer is D. All right, and let's see, how did we get there? All right, so I've got a few FTRs up under here, but we're gonna start here with code 32098. This is for thoracotomy with biopsy or biopsies of the pleura. Okay, well, we're having thoracotomy? No, no, that was not performed. All right, so this is just ticking off the box of no, thoracotomy. This person had a percutaneous needle biopsy, but this thoracotomy is a part that no, we're gonna take that one away. All right, so we're gonna keep on looking. Biopsy, pleura, percutaneous needle. Mm, it's pleura, but this is lung. Okay. It's the right lung lesion. This biopsy here was performed of the pleura with the percutaneous needle. Again, being very, very forensic. Okay. Just one word sometimes will do it. Yeah, that's reading really well. And if you're going really fast, you could miss it. It's a biopsy. It is with a percutaneous needle, but it's of the pleura. This is a percutaneous needle biopsy of the right lung. All right. So here, if imaging guidance performed, it's giving us all our parenthetical guidelines. But we know before we even get there, I'm not even fooling with the parenthetical guidelines if the code is incorrect. And so that one's incorrect. So we're going to take it off the table. All right, we're going to keep moving. All right, 32405. This is our biopsy lung or mediastinum percutaneous needle. Okay. And it's giving us 32405. All right. And it's saying percutaneous needle. All right. So we're going to give this a light yes. Okay. So this one here is, wait, let me look at, okay, I will look at it then. Okay. So I'm gonna finish through this one and then I'll look at it and then come double back. All right. So all right. So this one here, 32405, that you guys are telling me is not in this current manual, and I have the 2021. And I breezed through these last night, not even thinking about this one was done, was concentrating on all the other codes. So this one here with the 2020 is 32405, but I have my 2021 here. So I'm going to finish going through this one and then I'll double back and take a look at the other one. All right. So we took off 32607 because again, this is talking about a thoracoscopy. And then that's what's leaving us with D. So this is why everybody was going back and forth because I've got to pull out my other manual. All right. So reading those parenthetical guidelines, that's how we got here from our 2020 manual. And again, this add-on code, that was in all of them. And that was for the needle placement, the fluoroscopic guidance. That's how we got there using our other stuff. All right. And again, here, this is just for completeness sake that I always tell you where we're getting the codes from the ICD-10 manual. All right, so I'm going to go back here, tinker, and make the correction, y'all. Thank y'all for that. And then we'll move on to this next one, and I'm pulling out my other manual as well, y'all. I got a 99 manuals back here because I just hate to let them go. I do. All right, so we're gonna keep it moving. Don't take a screenshot of that one. This one right here is on point. I apologize. So hopefully, this next one, I know it's ready. It's ready to go. All right, so I'm gonna go back here and correct that thing. All right. you're going to be testing out of 2021, Miss Amy. Okay, so definitely take your 2021 manual, because you don't want, and you know what? That is a lesson as to why you have to take the current year's manual. All right, because that right there, you don't want to leave a point on the table because your book is outdated. All right, so let me go and correct that on my slide. Thank you, y'all. Okay, here we go, Miss Andrea.
Okay, coders, we have A 32850, 32856, 32851 times 2, B 32850, 32855, 32851, C 32850, 32855 times 2, 32850 modifier 50, and D 32850 with 32856 and 32853. A 27-year-old girl has been on the lung transplant list for months, and today she will be receiving a left and right lung from an individual involved in an MVA. This person was DOA at the hospital and is an organ donor. The donor pneumonectomy was performed by physician A, the backbench work by physician B, and the transplant of both lungs into the prepped and waiting patient by physician C. What is the correct coding for the removal? Physician A, preparation, physician B, and insertion, physician C of the lungs. You got this, coders.
All right, coders. I think everybody's got their answer in there. I wanted to be sure I gave everybody ample time to get those answers in there. Okay, I'm just taking a look at the chat. Aisha, I see you. I will I will chat you and tell you what we did on the last one. Really the answer, I needed to rework that one. It was correct with the 2020 manual. The particular code that was correct is deleted in the 2021 manual. Okay, so that is the pivotal part of that. All right, so I think that we are ready to roll on this one. I saw like one or two people getting that last one in there. So this one, we're gonna go ahead and unpack it. All right, so here we go. And for this one, I do have my 2021 manual up on my desk, y'all. I do. So here we go. All right, so we're gonna take a look here. This is a 27-year-old. All right, they're here for a long, they've been on the lung transplant list and they're receiving a left and right lung today. They are getting this from a person who was DOA, and now they're going to go in for this transplant. So the pneumonectomy was performed by physician A, the backbench work by physician B, and then transplant of both lungs was performed by physician C. So this is indeed a team effort. So we have the removal, physician A, prep, physician B, insertion, physician C. All right. One thing I like to do when I began to code, and this may help you, I start looking up each of the codes. I look at my keywords and I start taking a look at what those lead codes are so that I can start really pinpointing on what's making one different from the other. The nice thing about this one is that all of them are the same. So we know this is where we're going to start for all of them. All right. So your answer is D. So here we go. We're going to start with the 32850 because these are the three possible procedures with a lung transplant: removal, backbench work, transplant. We're only coding those procedures that are performed. The 32850, okay, that's the removal, donor pneumonectomy or nectomies. This includes cold preservation from the cadaver donor. We know we're going to need that code. We know that because it's in all of them as well. Now, the other thing, we know there was backbench work performed. It tells us that we're literally just ticking off the boxes. All right, here's the sticking point that I believe that may have gotten some of you. 32855, it is backbench work for prep of this cadaver donor lung. This is unilateral. All right, remember we said they're receiving what? A left and right lung. All right, so we're going to need 32856. Look at there. Yeah, both lungs. It's telling us here and it's telling us there. So 32855, that's incorrect. We can take it off there and there. And you guys know I love to get it to 50%. Okay, so there, that's what we need. We've got a double lung transplant. So we need code 32856. We're going to continue on. Now we've got to figure out what else is going. We've got to place these lungs inside of the patient. We've got to actually perform this transplant. So we take a look at code 32851. This is lung transplant single. Okay. And this is this right here, single. No. Remember, we said that they had a double lung transplant. So this is where I was saying you want to look at both things. This could catch you because you're like, well, I got a multiplier, but you have an even better code down here. All right. How about 32853? Lung transplant double. Yeah, that's what we need. Lung transplant double without cardiopulmonary bypass, because that's not mentioned. And again, if the doctor didn't say it, it didn't happen. All right, so there we go. That's how we get to code 32853, and that's how we arrive at D. All right, I got some. Aha, gotcha. Yeah, You're just going to tick through the boxes. Again, these are your possible procedures, and you're just literally going down the line. And the nice thing about transplant codes, they're literally in order of how the procedure would be taking place. All right. So, how are my coders? All right. So, if anybody didn't get it, let me hear from you. Okay, let me hear from you that yeah, this makes sense now. Okay, good, good. That's what I want to hear. That you're feeling good. All right. So we're gonna keep it moving. And again, I am in my 2021 manual, y'all. I'll say it again, my 2021 manual. All right. Are you ready? Are you ready, Miss Andrea? I know you are. Come on, lady, and read the next scenario. Thank you, ma'am.
I am ready. A 31600 S21.309A V86.19XA B 31605 S17.0XXA V49.9XXA C 31603 S11.10XA V49.9XXA and D 3162 S21.309A V86.19XA. The surgeon makes an incision in the neck near the cricothyroid membrane for an emergency tracheostomy for a patient who arrives in the emergency room with tracheal crushing injuries suffered in a car accident in which the patient was riding as the passenger. What CPT and ICD-10 CM codes are reported? You got this, coders.
All right. I just saw my last few answers come in there, and I think you guys are spot on. Yeah, your answer is B. Yes, yes, yes. It is. It is. All right. I'm loving it. Okay. Hey, Miss Natalie, we're just here to just cheer you on. This is all you. You guys are working hard, and we are just thrilled that you guys have partnered with us to aid you along as you go on this journey. So let's unpack it. All right. So how did we get there? Yeah, you guys already know. This surgeon has made this incision in the neck near the cricothyroid membrane. This is for an emergency tracheostomy. This patient has arrived at the emergency room with tracheal crushing injuries. Okay, they've been in a car accident and they were riding as the passenger. All right, we're going to take a look here. Yeah, we're going to start with code 31600, tracheostomy planned. This was not hardly planned. This patient was in an accident and this was emergent. So we know right away 31600 off the table. We're going to continue on down here. We're going to take a look at code 31603, tracheostomy emergency procedure. Ooh, I like that. I like that. Yeah, but that's transtracheal. Okay. So this common cold language is correct, but that transtracheal, not so much. We're looking for the cricothyroid membrane. All right. So we're going to get rid of code 31603. But I love this dependent code right there. Yeah, that tracheostomy happened. It was emergent, but it was through the cricothyroid membrane. Yeah, you saw how I made that jump out for you right there. Yeah, that's why we need code 31605. We're going to give it a light yes. Okay. But before we say yeah all the way, let's do our due diligence and see what is code 31612. Well, that's for a tracheal puncture. All right. And so we know that didn't happen. No. Yeah, you see it now. Good. All right. So we take that one off the table and yeah, code 31605. That is your code. Yeah, don't take the bait because it's looking real good and it's only one answer at really not one answer but one specific wording for this code 31603. Again, this is the second time we've seen that one word can change what your selection will be. So I always train your eye to that semicolon. Anything before the semicolon is common code language for everything that falls within that code family. But anything after the semicolon is specific only for that parent code. All right. So we getting back to just the basics here, but the basics are oftentimes what will help you. That's what builds that foundation. So sometimes as we learn more, we have to go back and revisit those building blocks. So remember that everything before the semicolon, common code language applies to everything within this code family. Anything after is specific for the parent code only. All right. Okay. Yeah, no worries. This is where you want to have those little oops. Oh, wait. Oh, what? That's where you want to have them, where you're here with me. Train that eye. Continue doing what you're doing. You guys are well on your way. I'm loving what I'm seeing. All right. You know, for completeness sake, we're just showing you where we got this code for the crushing neck injury over in the ICD-10. That's how we arrived at that code, tracheal crushing injuries. Okay. And then we have the V49.9 because this patient was the passenger. All right. Again, when you are on that exam, stay out of that ICD-10 until you have to pull it out because you have things to either break a tie or you have specific questions related to it. All right. Okay. All right, Miss Andrea. Come on, lady. You have the floor. I appreciate you.
Okay, we have A 31231 with 31267, B 31254 with 31256, C 31256, and D 31267. A patient is seen in the endoscopy suite for a diagnostic maxillary sinusotomy. During the sinusotomy, the provider observes some diseased tissue which needs to be removed. The provider decides to perform a maxillary antrostomy with tissue removal. Bleeding is controlled. The patient tolerated the procedure well. What CPT codes are reported? And you got this, coders.
All right, coders. Yeah, I see some good stuff in there. Good stuff. It is okay, Miss Susie. That's a good thing, lady. That's a good thing. All right, guys. Let's go ahead and unpack this thing. Yeah, I see some more answers coming on in there. I see y'all coding this morning. I see y'all code. That is all right, Miss Natalie. That is all right. We got you. We got all of you, okay? So if you guys were like, not quite sure, that's okay. That's okay. It's all right, Miss Lorraine. It is okay. All right, guys, let's unpack this thing. I had just a few of you were kind of going back and forth, and you know what? I work these things often, just preparing for class, and which is what tickled me with that prior scenario where I had the 2020 codes. It was because I was coding out of the 2020 manual. Don't ask questions, y'all. Okay, I'm preparing for the CCS exam. So anyway, I got the right book now. All right, so here we go. The answer is D. What? How did we get here? I'm gonna tell you why, Miss Natalie. I'm gonna tell you why. All right, so they're in the endoscopy suite. This is for diagnostic maxillary sinusotomy. During the sinusotomy, the provider has observed some diseased tissue and that needs to be removed. So they've decided we need to perform this maxillary antrostomy with tissue removal. So how do we get there? Well, we're going to start out with code 31231. This is nasal endoscopy diagnostic. Well, we already know diagnostic, unilateral or bilateral. Well, we already know it was no longer diagnostic. Once a provider, or in this case, the surgeon, goes in there and starts doing something, they're no longer only just looking and diagnosing something that's going on. Once they start to perform something, then it's surgical. So we already know that code 31231, diagnostic, that's incorrect. We're going to take that one away. All right, so we keep on going. We have code 31254. Okay, and that was nasal sinus endoscopy surgical with ethmoidectomy. All right, well, no ethmoidectomy was performed. We were working with this maxillary, okay, the maxillary sinus, okay, maxillary antrostomy. So we keep going and we have code 31256. This is nasal sinus endoscopy surgical with maxillary antrostomy. Well, I like that. We need to code to provider certainty and specificity. So this happened, but we also had some tissue that was removed. Okay, so while this specific code, remember I was telling you before, all of this code language prior to this semicolon, that's spot on. All right, but there's nothing more. While this isn't wrong, it's not the best answer. We need to code to provide a certainty and specificity, and we have an answer that's better and more specific, and that's code 31267. This happened, the maxillary antrostomy with tissue removal, with removal of tissue from the maxillary sinus. Yeah, there we go. See how I made that jump out at you? Let me do that. Yeah, that's why we go with code 31267. And then we have all these things that we our do not report codes and then our parenthetical guidelines. But we know that 31267 is just what we need. Yeah, that chunning, it helps a lot. This particular code gets lost in all of these parenthetical guidelines. So what I would suggest that you do with this one is box this code in so that you can see it, particularly if you have a lot of highlight. For me, with parenthetical guidelines, when they start bleeding into other things, I don't, and this is just my personal preference, I won't highlight through like this in my personal manual. I will literally take my yellow marker and just make a line through it. So I bring my eye there, but I don't have all this yellow going because this code will get lost. And I have a sneaky suspicion that that's what happened with some of you. This code got lost. The other thing is when you see this semicolon after the parent code, you know it's a parent because it's got that semicolon. It's letting you know, hey, I got some babies. I got some dependents, y'all. You need to start looking. Okay. All right, so hopefully that's a teachable moment for you. You can grab a screenshot if you want to, but again, 2 lessons in there: code to provider certainty and specificity, especially if you have the choice of the code, and be aware that semicolon is pivotal. Sometimes the parent code won't have language after it, but this language applies to this code. But this is telling you there's more here. So keep looking. Okay. All right, we're going to keep on trucking. All right, you ready? You ready, Miss Andrea? You know what? I'm trying to figure. I'm not gonna do that one. I'm gonna do. Give me 1 second, guys. Um, that one's a pretty simple one. I want to get to one that might cover a little bit more ground. It's simple, but it does have a good concept. I want to be sure you got it. Okay, all right, Miss Andrea. Let's do it, lady. You have the floor.
Alrighty, we have A 30115, B 30110 with 30115 times 6, C 30115 times 7, and D 30115 with 30115 modifier 51 times 6. What CPT codes are reported for extensive excision of 7 nasal polyps? You got this, coders.
All right, coders. I've seen everybody's last few answers in there. And so we're going to go ahead and unpack it, okay? You guys are doing outstanding. If you just missed it, no problem. I'm going to get you there. And then some of you just needed a nudge, which was the case for most of you. So we're going to go through it and be sure you've got this concept down. Yeah, it is A. Okay, it's amazing how something so simple, it can test a lot of different things, and that's often my goal, is with each scenario to test you on several different things, because we only have so much time. So I'm trying to squeeze a whole lot of layered things in there for you. All right, so this CPT code or codes, how's it reported for extensive excision of 7 nasal polyps? Okay, all righty, so here we have it. Excision, nasal polyp or polyps, simple. Well, we already know that this was extensive, so it is not extensive, okay? So this one right here, we're gonna take that one away right off the bat. All right, this one right here, okay? This is excision, nasal polyp or polyps, extensive. Okay, yeah, that's good. Yeah, polyp or polyps. As soon as we see that, even though it's 7, we're covered. Whether they remove 1 polyp, 7 polyps, 10 polyps, we're covered, and it's extensive. So we already know, because of that, all right, we can get rid of, that's our code there. We can get rid of that multiplier. We can get rid of D, because we can't decrease the services to try to make it, it's no need to not decrease the services. It's no need to say we have multiple procedures going on. What they're trying to do is say that's for 1 polyp, and then this one right here, this is for the other 6. That gives us, we don't even need to do all that, because of that. That little bitty word right there takes care of all those multipliers that they're trying to apply. So that's why code 30115 is the code. And I know somebody was saying, yeah, but about that hospitals, it normally would require hospital facilities. Okay. But here's the thing, it doesn't say anything about even where it's taken place. And even if, regardless of where it took place, it's just telling us normally it would require those facilities. All right. All right, I got some. Oh, okay. I know at first you guys were thinking, why is she giving us this little things? A lot of times it's the small stuff, okay? All right, give me 1 second. I am going to um, get us to some musculoskeletal. We're gonna go ahead and leave respiratory. I think you guys are ready. You guys have been flexing. You're showing me what you got. You're showing me that you're ready, okay? So, hey, we're going to spend the next hour going into some musculoskeletal scenarios. I know you're ready. You're ready to get that workout on, okay? Let's go ahead and lift some heavy stuff, some heavy scenarios. I'm just going to give you guys just this little quick one here, okay? So ladies, like, ready. Yes. All right. So I'm not even going to mute myself. I want you guys to tell me, what is the chromium? Okay, yeah, I see some answers popping in there, and I sometimes would just pop some little questions like that in there. I want to be sure you're orientating yourself. It's good to have a general idea where these muscles are. You don't have to memorize anything, because our books give us wonderful diagrams and things. So if you are ever coding and you're not sure where you should be, take a look at the front of the specific code chapter if you need to orientate yourself to where you are. All right. So indeed, the scapula, uh, it is an extension of the extension of the scapula is what the acromion is. Okay, that's what the acromion is, and I'm going to show you right there, that little notch. If you feel right up there on your shoulder, that's the acromion right there. Okay, and it's an extension of the scapula. All right, here's the scapula right there, and then you see all these ligaments are linking it to that, but all of that stuff works and moves together. All right. Yeah, Renata, I knew you knew that. See, as soon as you see it. And you guys have your manual, but really that's just an exercise of knowing where to look to find something. Because if you have a question like that or something on your exam, I want you to get that thing. Don't leave anything on the table, okay? Especially some simple things. Yes. All righty, Miss Andrea, you have the floor, young lady.
All right, we have A 21325, B 21310, C 21315, D 21337. The patient presents today for closed reduction of a nasal fracture. The depressed right nasal bone was elevated using heavy reduction forceps while the left nasal bone was pushed to the midline. This resulted in good alignment of the external nasal dorsum. What CPT code is reported for this procedure? You got it, coders.
All right, guys. I think I have heard from everybody. I wanted to get everybody a chance to get those answers in there before we start tinkering away at this thing. All right, if you didn't quite get there, that is okay. I'm gonna help you get there. That's why you're here. I'm loving the effort and I am loving the participation because this is where you you hone your skills and really just fine tune some stuff. Okay, so I've had a split between B and D, and that's okay. I'm going to give you some clarity on this thing. I had a few a few other answers going in there, but that's okay. We're gonna unpack it and show you how we got to the proper answer. Okay, so I'm just still looking there in that chat, and I think I have gotten Everybody. All right. Okay. And Miss Andrea's got my bag too. Here we go. All right. It is C. Yeah, it's C. For those of you who didn't get there, I'm gonna show you something with this. Okay. All right. So this person is here for a closed reduction of a nasal fracture. The the depressed right nasal bone was elevated using heavy reduction forceps, while the left nasal bone was pushed to the midline. All right, here we go. I like to give you just some details every now and again. A reduction of a nasal fracture is the medical term for setting the nose back into position. Stabilization is the use of an external nose splint to stabilize the 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 fracture. Okay, so here we go. We have code 21310. This is closed treatment of nasal bone without manipulation. Okay, closed. All right, but this is without manipulation. Well, we know manipulation took place. What was the manipulation? Well, we know it's closed, but they use heavy reduction forceps. So they're moving this bone around. They're manipulating it because it needs to be put back into position. All right. So 21310, that one's gone. We continue on and we have 21315. All right. Closed reduction of nasal bone fracture without stabilization. All right. Well, stabilization, see, I've told you what that is now. It's the use of an external nose splint. That would be an example of something that they would use. And this is of the nasal bone, okay, closed. The nasal bone was pushed. All right. So, yeah, it was reduced. See, when you push it, that's manipulating it. So they've reduced it. All right. So we're going to give that a light yes because we know, yeah, they didn't do anything with stabilization. And I know this right here is what will throw you. That without stabilization, they didn't use stabilization. They didn't put a nose splint on it. They used some forceps and simply elevated the nasal bone and pushed it back into position. Okay, so we're going to take a look at what we have left. 21325. We know that didn't happen. This was not open treatment. That's easy to take that one off the board. All right. And 21337, again, closed treatment, looking good, reading just like that, but this is nasal septal fracture. Remember, I told you one word can make all the difference. I'm telling y'all, I have to get my glass lens wipes out sometimes. Okay, you might have your forensic glasses on, but every now and again you got to get a glass wipe to those things, right? So 21337, that wouldn't do. All right, and that's why 21315. Uh-oh, let me go back there. That's why that's our code, okay? Yeah, okay, you're welcome, Tiffany. That's right. Yes, that septal fracture. No, this was a right nasal bone fracture. See the difference there? Just those little bitty things. And I thought, you know what? Let me give them the meaning of these particular terms that are being used, the difference between a reduction and stabilization. It makes the difference. It makes this particular scenario, it makes it pop. It really like, oh, whoa, okay, I got it now. All right, if you need to get a screenshot, you may, and we're going to keep on trucking through this respiratory system. We've got some additional scenarios to share with you, beautiful coders. All right, Miss Andrea, I need you, lady. Come on to the floor. Thank
All right, we have A 20552, B 20553, C 20610, D 20553 times 3. A 39-year-old involved in a motor vehicle accident a year ago arrives to the pain clinic with complaints of neck pain and left-sided radiculopathy complicated by cervical degenerative disc disease. NSAIDs and physical therapy have been unsuccessful, and the patient requires multiple trigger point injections. The left multifidus, trapezius, and right levator scapular were injected. The area was cleansed and bandage applied. Which procedure codes best describe this encounter? You got this, coders.
All right, how we looking in there, coders? I think I've heard from everybody. If you hadn't quite gotten that answer in there, go ahead and slide it in there. Yeah, I just saw one more. I'll take it. All right, you guys were spot on. For those of you who needed a little nudge, we gave you one and you got there. Yeah, I'm telling you, I mean it when I say this CPT coding thing, it looks good on you, y'all. It looks good on you. All right, well, we're going to breeze through because you guys, I don't think you need much explanation. The answer is indeed B. I always like to go through because maybe in my explanation, I'll give you something else that you can use and apply as you're coding, okay? So here we go. These are our keywords. This is a 39-year-old. They've been in an MVA. They are complaining of neck pain and left-sided radiculopathy. It's complicated by cervical degenerative disc disease. They're coming in because they need some relief, so they're going to have some multiple trigger point injections. They're going to have one of the left multifidus, the trapezius, and the right levator scapula. They're going to be injected. These are all muscles, and yeah, we're going to have those FTRs right there on the page. That's our roadmap. That is our GPS, so to speak. So we're going to start off with this outlier, as Miss Tracy would say, 20610 arthrocentesis, aspiration or injection of major bursa or bursa. No. We right when we read this arthrocentesis aspiration, we're coding for multiple trigger points. Okay, yeah, let's go ahead and get rid of him real quick. Okay, incorrect procedure and the type of joint is not correct. We're looking for some muscles. All right, how many muscles or joints do we have? And we know we don't code according to the number of injections. They're having multiple. It doesn't matter if they had one, if they had two or three. So we go up here to 20552. Yeah, injections. All right. So again, there we go. Everything before that semicolon. That's all it's saying. So that's why I'm always stressing those semicolons. You can read over them, man. They're little, but they're mighty. Okay. So we've got injections. That's our common code language. This single or multiple trigger point or points, one or two muscles. This is what's specific for code 20552. All right. Yeah. Okay. One or two muscles. We got more than that. Look at there. One, two, and three. Those three muscles were injected. And so once we know that, 20552, that comes off the table. We don't have enough muscles with that one. We've got three muscles. This will only give us enough for one or two. Again, that's why you pay attention. That's incorrect, but boy, do we need this. Injections. All right, this semicolon tells us, hey, look a little further. I got some dependents you maybe could use. And indeed it does. We have here injections, single or multiple trigger point or points, three or more muscles. This will take care of it regardless of how many trigger points we have and really regardless of how many muscles we have to inject. It still would be the proper code. Three or more muscles. I like it. 20553. We know that's our code. Now it's a matter of don't take the bait, y'all. Don't take the bait. Why wouldn't we do that? Yeah, the number of muscles injected is integral to the code language. Therefore, no multiplier. No multiplier. Yeah, that's right, Rasha and Tiffany. We've got three muscles. Yeah, that's right. That is right. I see you guys. Kiara, you put it in your keywords, and I see several of you did as well. Yeah, that's why we've got code 20553. All right. I don't think you guys need the screenshot, but if you want it, if you want to pull it off, just to notate and remind yourself that when you have the code language that's integral to the code, you don't have to worry about the multiplier if it's speaking particularly here, point or points. All right. I always stress this. Then you don't need that multiplier because it's taking care of it. And this code language here is taking care of the muscles. I don't care how many we got to inject. All right, here we go. Uh-oh. Get your fork. Get your fork and your plate and all that stuff because this one's meaty. They're ready to dig in, Miss Andrea.
All right, we have A 23615 LT, B 23605 LT, C 23616 LT, D 23670 LT. A 66-year-old sustained a left proximal humerus fracture. Standard deltopectoral approach was used and dissection was carried down to the fracture site. The fracture site was identified and fragments were mobilized and the humeral head fragments removed. Once this was done, the stem was prepared up to a size 10. A trial reduction was carried out with the deployed trial stem and implant head. Sutures were placed in key positions for closure of the tuberosities down to the shaft, including sutures through the shaft. The shaft was then prepared and cement was injected into the shaft. The implant was placed. Once the cement was hardened, the head was placed on Morse taper and reduced. A bone graft was placed around the area where the tuberosities were being brought down. The tuberosities were then tied down with the suture previously positioned. This gave excellent closure and coverage of the significant motion at the repair sites. The wound was thoroughly irrigated. The skin was closed with Vicryl over a drain and also staples in the epidermis. A sterile dressing and sling was applied. The patient was taken to recovery in stable condition. No immediate complications. What CPT code is reported? You got this, coders.
All right. Does everybody have their answers in there? We're going to go ahead and start talking about this thing. I see some folks sliding some more in there, so we'll take it. I'm going to give you time to give us your answers, and then we'll go ahead and spill the beans, so to speak, as to what the answer is and how we got there. All righty. Okay. Some of you I know were like, I'm not sure. I don't want to. I don't want to say just yet. I'm torn. I'm torn. Go ahead and tell me which one is your best guess. Your best guess. Best guess. That's all we need. It's tough when you get it down to 50-50. It's a good thing, but when you can't commit, yeah, we gotta bubble something on the page, right? We gotta bubble something. All right. I think I see everybody has made their selection. All right, here we go. The answer is A. All right, yeah, these right here, they used to give me fits as a student, and I'm just like, really? How many of those can I skip and still be okay? I don't want you skipping nothing. Okay, here we go. All right, so we've got this 66-year-old. They have a left proximal humerus fracture. They're going to use the delta pectoral approach, and they're having dissection done. They're going to go all the way down. They're looking at these fragments. These fragments were mobilized. The humeral head fragments were removed. They have had a reduction carried out with a Dupai trial stem implant head. They have closure of the tuberosities was done. The shaft cement was injected into the shaft, and an implant was placed. And there was also some reduction done. There was a bone graft as well. Then the tuberosities were tied down. All right, so we've got dissection and fragments removed. And we have this left humeral left proximal humerus fracture. So we're going to start up top here with code family 23600. All right, this is for a closed treatment. Well, we know right off, okay, even before we start reading on down, all right, this was open because dissection took place, okay, before we even get here. All right, this is incorrect. So if anything before any common code language reading before this semicolon is incorrect, anything that falls beneath it is incorrect also. So remember that, okay? So that common code language is incorrect. The dependents are going to be incorrect. Also, the common code language, again, being everything before the semicolon, they're talking about closed treatment. There was a dissection done. This patient was opened. So code 23605, that's gone. We come on down here, we look at 23670. This is open treatment, but this is for a shoulder dislocation, okay? We are dealing with the humerus. Yeah, you saw I made that jump out for you. 23670. Yeah, we're going to get rid of that one. All right, now I saw several of you had gotten it down to A and C. Some of you landed here, and probably because you saw this with the open treatment, the tuberosity, and all that stuff. Again, orientate yourself as well. Flip to the front of that book, because then you know what, I could take this off. Even if all this stuff is looking good, the fact that they're talking about the shoulder, you know where that is. But sometimes you need to take a look to see where's that humerus bone, where's this muscle, where's the location, because you're like, is this a bone, is this a muscle, what is it? Take a look in the front of that book so you can orientate yourself, and you realize, hey, with that humerus, I'm in the wrong location. All right, so we take that one off. What's this 23615? What are they talking about? Open treatment of proximal humeral. Yeah, that's looking good, man. That's looking real good. Surgical or anatomical neck fracture. Yeah, open treatment of proximal humeral fracture. Boom, spot on. Includes internal fixation. Yeah, we had all that stuff going on. When performed, includes repair of tuberosities. When performed, all of those things were going on today. All right, open treatment, proximal humeral. Yeah, includes repair of those tuberosities. Yeah, look at that. Humeral head, closed tuberosities. Yeah, includes the internal fixation. Look at that. Implant was placed. Here is the sticking point. Okay. All right. Implant was placed. We're going to give that a light yes, because we need to take a look here. Look at this. 23615. What is that? With proximal humeral prosthetic replacement. There we go again. That one word. That one word threw a wrench in it, y'all. 23616. Yeah, they didn't have a humeral prosthetic replacement. The implant was placed. This is new. It'll tell you if it's a replacement. They weren't going in and doing a replacement. They placed an implant. That thing is new. That thing is brand spanking new. So 23615 with an LT modifier because this is the left proximal humerus. That is the code. Yeah, I'm glad that that's an aha moment right there. All right. Okay, so is everybody sure on this one now? I know it was a lot to unpack, but I hope in doing some of these longer scenarios that are a bit more involved, that don't shy away from it, start to unpack it and really dig in. I'm teaching you guys to really dissect those codes and how to help yourself get to the right code by also taking advantage of everything in that book, those diagrams and things. They're there for a reason. So take a look. If a word doesn't look like, what is the humor? Is that the arm, the leg, or what? Look at it. Okay. So if they're talking about the shoulder, you know, like, wait a minute, whoa, 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 that's not right. Okay. All right. So we're gonna keep on going. All right. So is everybody ready? I think you guys are. All right. All right, Miss Andrea, you have the floor. I'm gonna advance my screen. We're gonna do a quick one, okay? All right,
All right, we have A 29805, B 29806, C 29807, and D 29819. A patient is seen in the same day surgery unit for an arthroscopy to remove some loose bodies in the shoulder area. What CPT code is reported? You got it, coders.
all right, coders. I see y'all in there. I see y'all in there. Yeah, I see lots of good stuff in there. Yeah. I love what I am seeing. Yeah, Miss Audrey, somebody's gonna have to bring me some tissue. I'm about to cry. Look at the coders. Y'all grow up so fast. Here we go. Yeah, it's CPT. All right, so we're going to breeze through this one. This is a same day surgical procedure for an arthroscopy to remove some loose bodies in this shoulder area. Okay, we just got through talking about that shoulder, the difference between that shoulder, all right, and the humerus. The humerus is the long bone of the arm, and the shoulder, that's different. Okay, that's not considered the same space and place. Great question for one of your fellow coders. Okay, so again, taking a look in the book to dig around, but here we are talking about the shoulder area. But this right here, arthroscopy, diagnostic. Remember what I said about diagnostic? As soon as a surgeon is doing more than just looking around to diagnose what's going on, to say what the problem is, it becomes surgical. Once he starts removing stuff or cutting stuff, it's a surgical procedure, no longer diagnostic. So we're taking this off the table, as well as the fact that this here, it's just not right. It's just not right. Okay, so 29805, we're taking it off the table. We're going to keep on going. We're not worried about these parenthetical guidelines because the code itself is incorrect. So let me pass that little tip on for you as well. Once a code is not correct, don't start fumbling with those parenthetical guidelines. Don't fuss with them. 29806, arthroscopy shoulder surgical, but this is for a capsulorography. Lorography. Yeah. Loraphy. There it is. Capsulorography. All right. That didn't happen. We are talking about removing some loose bodies. All right. And so that part doesn't fit. Okay. But here we go. That common code language again. There we go again. So this specific code that captures this code language doesn't fit, but this common code language, it does. So code 29806, we're going to take a pass on that, but we like this common code language, and this semicolon is telling us, while I might not be able to help you, take a look at my dependents, shall we? Here we go. So code 29807, repair of slap lesion, arthroscopy, shoulder, surgical, repair of slap lesion. That stuff is good, but that's not what happened. All right, and you guys were spot on. 29819, yeah, for removal of those loose bodies. I'll take it. I love it, love it, love it. Okay, so here we go. We're gonna sneak this one in. They're ready, Miss Andrea. I can feel it in my buns. Here we go.
Okay, we have A 27724 LT, S 82.122N, B 27722 LT, S 82.122S, C 27722 LT, S 82.102N, D 27724 LT, S 82.102C. A 47-year-old patient was previously treated with external fixation for a type 3A left lateral condyle tibial fracture. There is now non-union of the left proximal tibia, and he is admitted for open reduction of tibia with bone grafting. Approximately 30 grams of cancellous bone was harvested from the iliac crest. The fracture site was exposed, and the area of non-union was osteotomized, cleaned, and repositioned. Intrafragmentary compression was applied with 3 screws. The harvested bone graft was packed into the fracture site. What CPT and ICD-10-CM codes are reported? You got it, coders.
All right, how we doing, coders? Go ahead and slide those answers in there, okay? Because I want to unpack this one and squeeze one more in there, all right? I have already sent a quick text message to Miss Mashawn to tell her, hey, give us just a few more moments to work this one through and squeeze one more in, and then we'll exit stage left, all right? So here we go. All right, what is our answer? Let's take a look at these keywords first, okay? And see what did we do to get here. This is a 47-year-old patient previously treated with external fixation for a type 3A left lateral condyle tibial fracture. There's now non-union of the left proximal tibia, and they've been admitted for open reduction of the tibia with bone grafting. Approximately 30 grams of cancellous bone was harvested from the iliac crest. The fracture site was exposed, osteotomized, cleaned, and repositioned, and then intrafragmentary compression was applied with 3 screws. Harvested bone graft, okay? They had a harvested bone graft was packed into that fracture site. The answer is A. Yeah. Let's see. What did we do? And hey, if you didn't quite get that, that's okay. That's why you're here. That's why you're here. Okay, so we have for code 27720, this is repair of non-union or malunion tibia. That's good, okay? All right, now what's this 27722? Well, that wasn't mentioned. Okay, so we're gonna take a pass on that. We're looking for the fact that it was open reduction of this tibia with bone grafting. There was no mention of a sliding graft. So look at there, B and C is done. So again, taking note of what the keywords are reading, and sometimes it's a matter of, remember I said, take a look at those codes, see what they're saying, and go ahead and look real good at these 2 codes, because once you make this selection, it's going to determine the course that you take. Sometimes it's just that pivotal. Most of the time it is. We've got to take that away. There was no mention of that. Again, remember this common code language, that's good stuff. But this one right here, that code doesn't go. But what about its sibling here? 27724, repair or of non-union or malunion tibia with iliac or other autograft includes obtaining the graft. Well, yeah, harvested bone graft, all right, and we know that that was done. So we're going to give that a light yes. We know that that's our answer here, but what about this? Okay, we need to head over here, and before we even start unpacking what's what, I would jump right to the 7th character box here. All right, we're talking about it's good to know how you get there, but for testing purposes, there's certain things you can do to get right there. Okay, before I even show you that, in now subsequent encounter for open fracture type 2A, 3A, 3B, or 3C with non-union. What about this C right here? That's for an initial encounter of an open fracture. Well, they've already told us it was non-union, so already we know which one we need to take, don't we? We need to take A because of that N right there as the 7th character on that code. But hey, this is how we got here, S82.10. Okay, this is unspecified fracture upper end of the left tibia. Okay, this is left proximal tibia. Okay, so we have S8210. Okay, that's that. All right, we take a look at the other one, S82. All right, and here we go, SA2.12. This is fracture of lateral condyle of the tibia. Look at there, left lateral condyle tibial fracture. Condyle left tibial fracture. That's what we need right there. And then we're going to add that 7th character like I just showed you. Okay, and that gets us here. Okay, so we could also break the tie between A and D, like I said, verifying that 7th character right there. Okay, now that's for the initial encounter. All right, and we know they were previously treated, so this is for a subsequent encounter. All right, put that right there. Okay. All right, so how we doing, coders? If you need a screenshot, go ahead and grab it if you need it. We're going to squeeze one more in here. All right, Miss Andrea. I know they're ready. I'm glad I see some goods and some awesomes. Okay, let's just take a breath. We are doing respiratory today, and let's go ahead and do this next one. I think I want. Wait a minute. Yeah, let's do this one. We'll do this one. I always load us up with a whole lot of stuff in the treasure chest. We just don't ever have time to do it all. But let's do this one. This is a good solid one as well. All right, Miss Andrea. Thank you so much, young lady.
Alrighty, coders. We have A 20551 with 73040 modifier 26, B 20610 with 73040 modifier 26, C 23350 with 73040 modifier 26, and D 20552 with 73040 modifier 26. A 49-year-old female had two previous rotator cuff procedures and now has difficulty with shoulder function, deltoid muscle function, and axillary nerve function. An arthrogram is scheduled. After preparation, the shoulder is anesthetized with 1% lidocaine, 8 cc without epinephrine. The needle was placed into the shoulder area posteriorly under image intensification. It appeared as if the dye was in the shoulder joint. A good return of flow was obtained. The shoulder was then mobilized, and there was no evidence of any cuff tear from the posterior arthrogram. What CPT codes are reported? You got it, coders.
All right, coders, how we doing? How we doing? All right, I see some answers coming in there. I like it. Go ahead and slide them in there, and we're gonna go ahead and start talking about this thing. I am loving the effort and the energy and just the commitment that you guys are showing by coming on Saturday and giving it your best. We certainly um, hope that this is definitely worth your time. We're doing our best to make it worth your time. Miss Andrea and I have been in your shoes, and we know what it means to turn the corner and have to start eyeing that exam. But it is our mission to get you ready and to get you there. Okay. So let's go ahead and talk about this thing, and then we're going to let you guys out of here so you can begin your wonderful weekend. All right. So I just finished throwing me a few answers in the chat because Miss Andrea does such a beautiful job in there. So yeah, our answer is C, and yeah, with a little nudge, and everybody got there. Yeah, this 49-year-old, they've had two previous rotator cuff procedures, and they're coming in for this arthrogram. The shoulder has been anesthetized, and a needle was placed in the shoulder area posteriorly. And then we had that dye that appeared in the shoulder joint, and the shoulder was mobilized. All right. And then there was no evidence of any cuff tear or post from the posterior arthrogram. All right. So we know an arthrogram. That's what we're dealing with. And we have a needle that's been placed in the shoulder. And again, arthrogram. So we probably need to train our eye to that. We're going to look at code 20550. Okay. That is our parent code. Again, focusing your eye on the fact injection, but hey, we're talking about an arthrogram. All right. This is injection, single tendon sheath. Regardless of how it's reading, we're talking about an arthrogram. All right. So single tendon, all that stuff. But once this common code language and everything is not quite right, because we have more going on, then we know that the dependent is going to be incorrect as well. So we're not even going to fool with the parenthetical guidelines. This is simply injection, single tendon sheath. No, that's not it. We need something more. And we also know, looking here, 20552, injection, single or multiple trigger points. Again, this is talking about trigger points and injections. We are talking about an arthrogram was done along with this shoulder and with the shoulder injection, with this needle being placed. Okay, the needle was placed, but an arthrogram was done. So again, real specific in the wording. You got to watch it. This is an injection. Again, this is for multiple trigger points. So now we're going to take a look now at 20610. This is arthrocentesis, aspiration or injection. All right. No, again, hone your eye there. Okay. Arthrogram 20610. This is arthrocentesis. This is a matter of being able to look at the code and being clear about what the code is saying, but more so what they're asking of you in this scenario. When we take a look here at 23350, again, a code that is better. There we go. Injection procedure for shoulder arthrography or enhanced CT MRI shoulder arthrography. Yeah, we've got the injection, but we had this arthrography under image intensification arthrogram. And here we have that. Okay, for radio arthrogram, we need to use what? Code 7340. Yeah, we're in the right spot. Yeah, under image intensification. That tells us. And then we have all those parenthetical guidelines there, but we already know we've gotten what we need right there. So code 23350 along with code 73040 with a 26 modifier. That is indeed your answer. Okay. All right, coders, you guys did well. We don't have time to go further. There we go. If you need to get a screenshot, go ahead and grab that screenshot. Again, thank you guys so very much for hanging out with us. You guys know it is our goal again to partner with you to get you to your goal of your certification. Please leave us your feedback. Let us know what we can continue to do to help you to that goal. All right. It does help AMCI deliver quality classes for you. It helps me to help you. That is my goal. That is Miss Andrea's goal. We want to see you succeed. No feedback means no good. Let us hear from you guys. It doesn't have to be a whole big paragraph. Just drop us a line or two. We do wish you guys a most enjoyable weekend. Thank you for joining us today and sharing your most valuable time with us. You are so appreciated. We'll be here next week. And yeah, cardio's next week. And before we go, come on, Miss Andrea, you are my right hand lady. Come on.
Thank you so much, coders, for spending your Saturday morning and part of your afternoon with us. You guys have done an amazing job, and I could not have said it any better. Miss Tamika said it all. Thank you for being here. I've seen the growth already, and I'm looking forward to seeing you guys next weekend. Have a great rest of your weekend.
Thank you so much, Miss Andrea. You are appreciated as well, young lady. Coders, again, you are so appreciated for spending this time. We are humbled that you would share 2 full hours of your precious Saturday with us. Thank you so much. Next week, we're doing all things related to what? The heart. Stop the beating of my heart. I'm telling you, Miss Andrea, I got to get the tissues. They going to make me cry in here. Y'all are growing. I see it, y'all. I see that certification. All right. I certainly hope you do too. We'll see you soon. Enjoy your weekend.